Welcome everyone to the first in a series of 2 webinars that we are hosting here at the European Observatory on Health Systems and Policies on primary healthcare. The next one will be next week. Both webinars draw from the Primary Healthcare Global Report, or the Primary Healthcare Primer, which we launched a couple of weeks ago at the WHO Primary Healthcare Conference in Astana, Kazakhstan. And this will be available soon in an online version in early 2024. And the link to be notified when it goes online will be put into the chat box to all those interested. My name is Deepa Rajan, and I will be the host and moderator for you today. Today, we're going to be talking about the integration of public health and primary care, a big topic in European health systems today. We know that there are approaches to integrating primary care and public health which range from mutual awareness on the one side through to cooperation, collaboration, and in rare cases, full integration involving a single, fully merged organization with sometimes even a shared budget and a shared plan. So today we're going to be hearing from 3 country speakers from Estonia, Slovenia, and France to see how that works in practice. But before that, we'll be kicked off with a keynote presentation by Andrew Pinto, who is an associate professor at the University of Toronto and a public health and preventive medicine specialist and GP at St. Michael's Hospital of Unity Health, Toronto. Before we get into the keynote presentation, however, we're going to run a short poll to learn more about you, the audience. And for that, I'll hand over to my colleague, Erica Richardson here at the Observatory. Over to you, Erica.
Hello there. Thank you very much. Yes, if we could launch the poll, that'd be fantastic. So just 2 quick questions to see where we are as an audience. The first one is a broad one. Is there any integration of primary care and public health services happening in your country? So that's a yes, no, or a quite legitimate don't know option. And then which are the areas where integration is already happening? So is it in health protection, health promotion, disease prevention, surveillance, emergency preparedness and response, all of the above, or indeed none of the above? So yeah, share your experience from your country. I'd be really interested to hear it. Thank you very much. Back to you. Over to you, Andrew.
Thank you so much and welcome everybody. It's a real pleasure to give this talk just to open the conversation. I'm going to present on what we learned in this area in about 15 minutes, and then we're going to go into the discussion about each of the 3 countries. I want to just begin by acknowledging where I'm located, which is in Toronto, Canada, and something that is important for us in acknowledging our history of colonization is noting that the traditional land here is of the Huron-Wendat, the Seneca, and most recently in Mississaugas of the Credit, and Toronto is covered by Treaty 13, and there's specific calls to action for those of us working in healthcare by the Truth and Reconciliation Commission. So something that I want to keep in mind as I do this type of work. I direct a research team called the Upstream Lab based in Toronto, but working with colleagues around the world. And also, as was mentioned, I come to this topic as both somebody who is trained as a GP, as a family physician, and I work as a family physician about 25% of the time, but also trained as a public health specialist. And a lot of the work that we're doing is related to public health interventions. And so this work and what I'm going to speak to derives from this primer, and specifically a chapter that we did on integrating public health and primary health care. And I just want to acknowledge my co-authors, Arnaldas, Jane, Vejna, and Martin on this work. And it was supported by the WHO and the European Observatory. So I wanted to begin by just first bringing our attention to the World Health Organization vision for primary health care in the 21st century. This was a vision that was developed over a number of years and published in about 2018, and is a really foundational kind of idea and set of ideas to say where in this century, where could we go with primary healthcare? it has long been identified, dating back to the 70s, with things like Alma Ata as the foundation for health systems. But this, as we are entering this century, it was a really good opportunity to revisit. And this vision, which I encourage everybody to really kind of dig into, had these three core parts. Primary care services, of course, along with essential public health functions as a core of integrating health services, but also these two other areas, multi-sectoral policy and action, and empowered people and communities. And that these three parts have to work together for us to achieve this really amazing vision of what primary healthcare could be. And that this is kind of the foundation of our work and thinking about this idea of integration with public health and how that could actually work. So I want you to keep this concept in mind and really think about, in your own country, how could primary healthcare evolve and become a system that has all three of these parts? What would that look like? So to start, thinking about integrating public health and primary healthcare, it's really important to remind ourselves of the definition of public health as the organized efforts of our societies to protect, promote, and research health through collective or social action. So it's a really broad concept of what public health is. This has been distilled into key roles for public health, which have been called the essential public health functions. And I'll go through kind of this in brief. These functions, it's important, are not just about supporting population health outcomes, but they can contribute to health system strengthening overall. And in our chapter, we have this really useful figure which outlines the essential public health functions, and also really kind of focuses on a few of them that particularly are relevant to collaboration and integration with primary healthcare services. Areas like health promotion, disease prevention, health protection, emergency management, and then overall surveillance and monitoring as well. So these are 5 kind of core essential public health functions, which seem to particularly fit well with what primary care services and primary healthcare overall is hoping to do. And so we kind of distilled what we learned from looking at the literature and looking at a number of countries around the world which were identified as leaders in this area. And we kind of focused on these 5 areas, which I'm going to touch on in brief with each of them: health protection, health promotion, disease prevention, surveillance, and emergency preparedness and response. And what, as Deepa mentioned at the start, we see that across all countries, they lie on some aspect of the spectrum. From, for example, in Canada, where I'm situated, I would say that we're very much at the kind of mutual awareness and communication, with some aspects of cooperation, particularly during crises like the COVID pandemic. But there are other countries, and I think some of the ones we'll talk about today, which go far, far more and actually are where it's fully integrated, including within financial lines and management structures and things like that. So just to go through each of these 5 areas briefly, if we think about health protection, primary care services provide a lot of important areas around health protection already: individual identification of risks that people can face, counseling, promotion of safety. For example, whenever I meet with families with young children, and part of the work that we're doing is counseling and helping identify risks, and this has helped drive down things like childhood injuries and deaths. But also, primary care can play an important role in supporting public health campaigns and actually working towards policy change and supporting that as well, whether it's around things like tobacco or alcohol, infectious disease, or environmental risks. And this is something that I've seen in many contexts working in different countries as well in the primary care system. Public health has an important role around policy, legislation, and enforcement of health protection efforts. around not only immediate risk, but also the upstream causes as well. And this is where they can view primary care services as an essential part of that work in both monitoring risk, but also as a way to disseminate and distribute actions across huge regions as well. Health promotion is a second area, and this is from the Ottawa Charter, classic health promotion key parts that all of us learn in public health. But often it's not always extended into the role of primary care services. So health promotion is about empowering individuals and communities to make healthy choices. There's this very strong focus on community action and mobilization. Primary care services can play a key role in that individual support, but also is starting to play a bigger role around the social determinants of health and actually mobilizing communities to get involved and actually take action on areas like green space, access for recreation, healthy food options in a community, and even going further upstream to think about things like democratic engagement, all through primary care services. Public health, of course, has an important role in coordination, and particularly is close to legislative and policy change as well. A third area is around disease prevention. And of course, primary care services have a key role in prevention, whether it's vaccination campaigns, screening, focusing on specific risk factors, and helping manage chronic disease. A lot of what I do as a family physician in Canada is often around chronic disease management. But public health has this huge role in this area around identifying patterns, engaging in outreach, particularly for communities that don't have access to primary care, and supporting multi-sectoral action. And this is a kind of a figure from the CDC, the Centers for Disease Control in the US, around what this could look like. What does effective chronic disease prevention look like? And multiple parts of that. A key area is around leadership, relationship building, which often can happen through the primary care system. A fourth area is around surveillance and monitoring. Now, for everyone in public health, of course, this is core to what the role of public health does. But I wanted to flag that what we're starting to see, and it's been now maybe a decade or two, is a growing idea of population health management within primary care services and within the primary healthcare approach. This is one example from Canada where colleagues have helped develop what's called the Canadian Primary Care Sentinel Surveillance Network, a network of really now over 10 systems and networks across the country that bring together electronic medical record data to allow for surveillance at a national level. I'm now helping as the director of our local University of Toronto network, which has over 400,000 patients involved in it and over 1,000 faculty members. So you can see the potential for this to support population health management is there, particularly as we get better and better at near real-time data collection, extraction, and processing. And we're bringing that population health lens to this type of work. One very specific project that we're doing is called Area RESP, which is using this for respiratory surveillance. And it's something that's emerged from the COVID pandemic. So there's lots of examples. This is just one of them. And then a fifth area is around emergency preparedness and response. Of course, during the COVID pandemic, we've seen this in many ways, where public health has a big role around preparedness and preparing for emergencies, developing community level plans, providing training, and actually planning out the service, and often plays a lead role in the incident management response team. Primary care service serves both as an early warning system as well as part of the response to the emergency. And this can be not only pandemics, but everything from natural disasters, conflict, and other things that can happen. A key aspect of this type of collaboration to make it work is information sharing, a shared prioritization of vulnerable groups, mitigating risks, and then also collaboration around how interventions are rolled out, particularly in a time of crisis. Something that really enables this is, of course, not waiting until there's an emergency, but doing a lot of work beforehand to build relationships, and even do things like tabletop exercises where people play out what their role would be in an emergency. So what are some of the things from the literature and from experience of people involved drives this type of integration? There was a few key enabling aspects. Having strong leadership and champions who really can work in both worlds of public health and primary healthcare, and also supporting change management, recognizing that change can be very threatening. And a big fear that exists within public health often is that funding will be taken away. And in almost every country around the world, public health receives a very, very small amount of the funding relative to the healthcare, service system. So that's always a big fear that the small public health is going to be co-opted and actually lose its power and funding to this much bigger entity. So change management is really, really key. Having people who are dually trained, and also ensuring that on both the public health side and the primary healthcare side, that there are specific competencies that enable people to be aware of what the other side is doing, and actually supporting much more joint training and doing things like those exercises that I mentioned. Data sharing and systems that support integration are key. It's very, very difficult if people have different data systems for there to be collaboration, whether it's around things like immunization campaigns, health promotion, or emergency management. There needs to be a shared vision and set of goals for this type of integration that ultimately is a win-win for both, and that at the end of the day, it's achieving the goals of both public health and primary healthcare systems. There needs to be funding mechanisms that specifically support collaboration, and not that there's a competition for the same kind of limited pot of funding. And integration can happen at multiple levels, and it can be synergistic. So it can happen at the very micro level, like within individual clinics and with individual patients. But it can also happen at like a meso level, at a local area, or it could happen at a national or macro level, or internationally as well. So just to summarize kind of the key points, primary healthcare and public health, they add value to each other. And this is a really central part of the vision for primary healthcare in the 21st century that the WHO has created. In every context that we looked at, the relationship is on a spectrum, and obviously a goal could be to move things along that spectrum to deeper and deeper integration. There are these 5 key areas which we identified, which really help make this very tangible of what it could actually look like. And there are a number of enablers that we found really help this actually happen. So I'll stop there, and really it's been a pleasure to do this work and to collaborate. I'm really looking forward to hearing from colleagues with the presentations of the 3 countries we're going to talk about. The chapter that will be coming on the primer has additional countries that were looked at as well.
Thank you so much, Andrew. And I'd like to pick up on some of those key issues that really make, as you say, make integration of public health and primary care tangible when it comes to implementation. So we're talking about leadership. We need champions to lead change management. We need dual training and competencies in both individual and population health. We need those shared data systems, shared visions and goals, and of course, funding mechanisms, which really incentivize moving together to closer collaboration. So we'll be hearing about how that plays out in practice in our 3-country panel. But before we hear from our countries, we'd like to see what the poll says. Go ahead, Erica.
Yes, so here are the poll results. About 2/3 of you say that yes, in your country, there is some integration of primary care and public health services ongoing. And while there's a pretty even all these areas are areas where this collaboration is happening. There does seem to be quite a focus around health promotion and disease prevention. So very interesting results. Thank you very much. Back to you, Deepa.
Okay, so I'd like to just introduce our fantastic speaker lineup. First, we have Vesna Petric from the Ministry of Health of Slovenia. She's head of office for cooperation with WHO, but she has a long career with the ministry in various roles in the Directorate for Public Health. She's headed the Division for Health Promotion and Prevention of Non-Communicable Diseases. She's also a member of the Executive Board of WHO. We have also Kaja Kasekamp from Estonia, who's currently a consultant with the WHO European Office for Health System Financing based in Barcelona. And she is formerly Ministry of Health Estonia and has worked as a consultant for the World Bank, for the Ministry of Social Affairs as the health equity lead, but also with the Estonian Health Insurance Fund. Then finally, we have Julien Mousquez from IRDES, or the French acronym for the French National Institute for Health Economic Research. He is the head of primary and ambulatory care performance research. And he's done quite a bit of research on care integration, on financial incentives for healthcare professionals working in primary care and ambulatory care. And has also advises the Ministry of Health and the National Health Insurance Fund. So we're going to start with the spotlight speaker from Slovenia. So I'll hand over to Vesna Petric for her to give us some thoughts on how primary care and public health integration happens in Slovenia. Over to you, Vesna.
Thank you very much, Deepa. I hope you all see me. And I'll start by saying that Slovenia is a small country in Central Europe, because I have seen that there are many people attending all over the world. My country has a long tradition, more than 100 years long, of public health and primary healthcare working together. And this should not discourage you, because despite this long tradition, my government had to invest a lot in the recent decades to make sure that this tradition does not fade away. But let me share the story. While many countries after the First World War, faced with the Spanish flu and malnutrition, tried to strengthen their capacities to better respond to such challenges, Slovenia responded by establishing public health stations and engaging primary healthcare physicians to reach population, in particular children, with a combination of individual and population measures. And based on this tradition, but also understanding that we have to further integrate public health and primary health care to address non-communicable diseases and related risk factors, we developed in early 2000 a new model of such integrated approach. Health promotion centers were developed in primary healthcare centers, community centers, with multidisciplinary teams to address risk factors in patients that were referred to these centers by their family physicians. After 10 years of operating in this way, evaluation of the work in health promotion centers has shown that free of charge preventive services such as smoking cessation, counseling in case of harmful use of alcohol or obesity were not attended by the most vulnerable population. People that were poor or coming from ethnic minorities, migrants, people with less education, were reporting in evaluation that they did not know about these services. Many of them did not attend preventive checkups with family doctors or were intimidated by their lack of knowledge, language difficulties, or cultural beliefs, and thus reluctant to attend. Based on this information, Slovenia decided to further invest and upgrade its preventive services. A pilot project was developed, engaging National Public Health Institute as a coordinator and obliging health promotion centers in 25 community health centers to reach out of healthcare centers to the community, involving social services, employment agencies, and NGOs such as patient organizations, Caritas, and Red Cross. The aim was to identify people most in need for preventive services, inform them appropriately on availability of preventive services, address their specific needs, and support them in attending programs, or bring programs to them in cooperation with NGOs and community nurses. At the same time, public health ensured municipality health profiles. These were data on health for the specific community, for the local administration and the mayors to understand where their community has a health problem and to make them invest in appropriate solutions. For example, in the community where obesity was above the national average, special events were organized by public health to inform public on nutrition, counseling, and primary healthcare services, and on opportunities for physical activity organized free of charge by the local community and NGOs. The pilot was a success in many ways, and in particular in mobilizing local communities for investments in health in many different ways. Training of professionals was upgraded and information for other stakeholders was developed, including for media. The number of participants from the most vulnerable groups attending preventive services has raised. Equity in health, one of the most important values of our health system, was addressed. Based on these encouraging results, a plan was developed to systemize the new model of community approach, integrating public health and primary health care interventions to reduce the prevalence of non-communicable diseases. Funding of this new upgraded function of Health Promotion Center was ensured through increased regular budget secured by the insurance fund for all primary health care centers in the country. A new role of National Public Health Institute, which included coordination, provision of local health profiles, monitoring and ensuring trainings, was agreed with the Ministry of Health and financed from the state budget. This model is now further developed to ensure integration or integrated approach also for mental health services. Thank you for listening to me.
Thank you so much, Vesna. I mean, so we can really see that Slovenia is a great example for this. It really brings together all of the elements that Andrew mentioned that are the drivers of integration or closer collaboration. You had the leadership, you had a shared vision and goal, you had a long tradition of training in public health, which you really took as a foundation and worked on. Then the data coming together, the data systems, funding that was there, public funding especially, and also a strong National Public Health Institute that supported all of this work. And I really liked what you mentioned about the community approach and the fact that you really worked closely with NGOs and with communities on this so that it was sort of a bottom-up and a top-down approach coming together. So you really set the tone for us by showing us how it should work. And let's hear from other countries to see how we can make it happen again. I'll hand over to our next speaker, to Julien Musquez, to tell us a little bit about France and its path towards public health and primary care integration. Over to you, Julien.
I will start with some very general comments regarding this issue. The fact that, of course, if you look at France, overall performance is very good in terms of life expectancy. If you see the capacity to facilitate access to healthcare and services are very large, the basket is very easy to get. And of course, we have the education system, both in the human sciences side and medical side, very performant. But also we have a large issue regarding primary care and public health. So basically, we could say that public health and primary care, both of them, are relatively weak, and the investment in order to improve and reaffirm both of them are increasing over time. It's only since probably the mid-2000. We have issues with main issues regarding the information and the main cultural determinants regarding public health. and education issues and inequality issues. So if we look at our main performance, of course, we do well in life expectancy, but if you have a look to the differences between male and female, for example, or between socioeconomic status or between location, you could see that there is some large issue regarding preventable mortality, for example. Also, we are not doing so well in the way we follow up for diabetes patient or other chronic patients. The difference in life expectancy between male and female is one of the largest in OECD and in Europe. Also, in terms of gap between life expectancy between blue workers and other workers, or depending on the income or on the level of education. Why all of that? Partly due to the fact that there is large risk behavior and risky behavior in our society, and if we just have a look to alcohol and tobacco, it's very clear, for which we have high level of utilization and consumption in France, larger than Poland, for example, for alcohol, or Spain for tobacco. And all of this is really driven by the difference in socioeconomic status, once again, education, occupation, wages, and income, and with large risky behavior in the lower educate or lower income or lower occupied people. Why all of this? One of the reasons, of course it's not the only one, is the fact that primary care is relatively weak in our country historically. Of course, there is a large amount of new policy in order to reinforce primary care in many directions. So if we come back to our main characteristic and weakness, it's linked to the fact that primary care was not the first, considered as the first and the greatest level of care since the origin. The planification of care and services was not really considered at the local level. And the fact that health human resources mainly involve physicians and are not always considering what could be the contribution for other healthcare professionals in that level of care. There is today a large geographical distribution both for physician and family physician and other healthcare professionals. The practice conditions mainly promote historically solo and mono practices, and there is only few of our healthcare professionals. We estimate that around 38% today working in a multidisciplinary group in primary care that involve both family physician and other healthcare provider like nurses or physiotherapists. And our payment mechanism for all the providers working in the ambulatory and primary care are linked to fee for services largely or mainly. All of this end with that we have to struggle with competition much more than cooperation and integration between healthcare providers could have complement in terms of public health and in terms of trying to transform the healthcare and services delivered in order to be more focused on prevention than on cure issue. Also, the fact that we are mainly focused on client-centered healthcare delivery much more than population-centered. So, of course, lack of consideration with public health. So, for our school, of course, there is some new direction in the policy regarding primary care and regarding public health. Let's say that there is three main areas of working. The one is in order to build capacity and framework in order to planify services at the local level, much more than at the centralized level. The fact that there is a way to introduce new payment mechanism for the primary care level of care in order to develop alternative to fee for services. And there is two main directions in this area. The one is to increase the share of payment mechanism linked to gatekeeping and to prospective payment. And the other one is to introduce pay for performance mechanism, and for some of them are linked to indicators and linked to public health indicators. And the third one is mainly linked to the fact that there is a huge policy at the state and the national level and at the local level in order to promote and to deploy a large number of multidisciplinary group practices that involve both general practitioners and other healthcare professionals, with the idea both to favor in favor of increase accessibility to this provider at the local level, which there is shortage area, and also in the direction of modifying the production function of the healthcare delivery in order to go much more in the direction of public health and of secondary and primary prevention. Regarding the shared data system, we have both huge strength since we have almost one unique big insurance, l'assurance maladie obligatoire, that covered almost all the population. And in this data system, we have all the claims that are regarding ambulatory care context. And this system is matched with hospital system. So if there is an hospitalization, you have the information for the patients. But on the other side, there is no clear evidence of capacity to match the data with other kind of information, both coming from regarding the socioeconomic status of the population or regarding the diagnosis related to every context, or that could help to match the data with the results coming from the radiology or the biology or others. So, of course, there is some strategy in order to match this data, but up to now, the big project called Health Data Hub is struggling with some specific issue of implementation regarding, for example, which cloud system should be built in order to be adequate in terms of regulation and juridic issues. So I think I'm done with the presentation before the discussion that will follow, I suppose.
Thank you so much, Julien. So we see that, France is making a lot of effort to bring closer collaboration between the two areas of public health and primary care, but it's still struggling a bit in terms of really getting a shared vision and goal and leadership behind this as a political priority. But then there are some initiatives, like you said, local planning, which is a way of jointly putting together a shared vision and goal. And you mentioned new payment mechanisms that will pay according to public health activities, for example, which aims at bringing that funding together to incentivize more public health and primary care coming together. We also see that data systems are really important, and that even though in France we have a huge data system with the mandatory health insurance, it still needs to be mined, and it needs to be linked to population related databases as well. So a long way to go, but also you've come a long way. Let's now turn to Estonia and hear from Kaja Kazakamp to see where one of our Baltic states is in this area of public health and primary care. Over to you, Kaja.
Hi, thanks, Deepa, and thank you for having me here for this important topic and important discussion. So firstly, a bit about Estonia as well, as it's such a small country located in the northeastern part in Europe. So many may not know the background sufficiently to put Estonia health system into and the policies that I'm going to talk about into perspective. We only have 1.3 million population, so very, very small, and we spend publicly on health around a little more than 5% of GDP. Though we have been hailed as being in this sense one of the most efficient systems in achieving quite good results and health outcomes with this public money that we put into the system. Nonetheless, as France, we have huge problems with inequalities in health, and for example, we we have one of the biggest as well gender gaps in life expectancy. And these are the problems that we try to address through our public health system. So when I was invited to speak here today, then I also mentioned that Estonia will not be a success story or telling telling other countries how to best integrate public health and primary healthcare services. They are very much in baby steps, but I can talk about some of the things what we have done thus far. So currently in Estonia, we are moving towards a multidisciplinary primary health care teams approach, increasing the role for nurses, which actually in itself increases the population health perspective as well. Furthermore, we allow providers to choose experts working in the multidisciplinary teams, which means that the providers can look at their population health and their population which is impaneled to them, and they can choose which kind of experts they would want to have in the team to serve better the needs that they locally do have. For example, whether they see a need for a speech therapist, psychologist, or a mental health nurse, and then we provide funding for these experts. Furthermore, we have a fairly long-term experience with pay-for-performance system, which incentivizes vaccinations, child health monitoring, NCD management at the primary healthcare level, which are all very well aligned with public health priorities and policy goals that we have set in the country and in our national health plans. So when preparing for today, I wanted to give some concrete examples where I think we have managed to collaborate quite well between the public health and primary healthcare level. And I think from Estonia, the best example raised during the pandemic. The primary healthcare system was struggling to adequately balance the response to COVID-19 while ensuring also the continuity of essential health services. And primary healthcare also played a vital role in addressing the effects of the socioeconomic consequences of the pandemic. And in this context, identifying the needs of the population and reaching out to those that had been disproportionately affected by the pandemic. So it was at that time very, very crucial. And so what we did, we were fortunately able to make rapid changes in the primary healthcare organization by introducing a system that no person, even without health insurance coverage or a family doctor, would be left without help. So hugely important from public health perspective during a pandemic, right? So we quickly reorganized to a so-called primary healthcare response center system, defining responsible primary healthcare centers from different regions to serve these patients who did not have a family doctor or insurance coverage. By this, we could ensure that everyone got their vaccination or they could get the referral for testing, because these were the main roles primary healthcare was given during the pandemic. And secondly, the family doctors in Estonia were given a role of vaccination, as I said, and they were provided a predefined list of patients in their catchment area who were, from public health perspective, being assessed to be high risk. And these patients were entitled to be prioritized during the vaccination. So our primary healthcare providers were actively reaching out to these patients, consulting on vaccination need, agreeing on a time for vaccination. And in this process, often the family nurses were taking also a leading role. A major benefit in the Estonian primary healthcare level is that they do know their catchment area very well. They are used to the outreach and invite patients for regular checkups. And this is thanks to the P4P or pay for performance system that we have in place. Primary healthcare providers also have the possibility to receive detailed data on their population health status from nationwide electronic systems. So we have in Estonia the privilege of very well integrated databases, and the information is very easily accessible. Already developed technical solutions have made a great impact, and nevertheless, we still see room for improvement there. For example, the data systems that are used, they are not, for example, fully integrated with social services, and finding the most vulnerable also through this lens. So this is something that we need to work more closely on in the future as well. But overall, the possibility and the availability of different integrating data from different databases and conduct such risk stratification and bring the data on hand to the primary healthcare providers, I think this has been one of the most important ways how we have tried to bring together public health perspective and primary healthcare in Estonia. And thank you for listening, and I look forward to the reflections and questions.
Thank you, Kaia. That was really a great example, really showing how, a data system that is quite integrated, maybe not fully, but pretty well integrated, can really be leveraged to provide the right information to primary care for providers to then target them for public health actions or preventive care actions like vaccinations or others. So yes, if we can get all of the panelists online and Erica to sort of feedback. I know we don't have much time, but maybe you can give us a few thoughts from the chat box. Go ahead.
Okay, so one of the key themes that came through the chat box is the need to follow the money. They're very interested in how you actually manage to finance these integrated services. So if anybody wants to give more details on that, it would be very, very welcome. Another issue that came up is one of governance. How do you actually manage these integrated services? And how do you even, and also, I suppose this links into the governance. How do you assure the quality? Does it improve the quality? Does it have no impact on quality? So that's another aspect of it. I think that's plenty to be going on with, given we've only got 10 minutes. Okay, thank you.
Okay, we'll start with the money. Anyone wants to answer that question? Tricky one. Besna, go ahead.
Well, it's not that tricky one, because as I shared with you, this was a pilot project. We invested European funding also in this. Slovenia is part of the European Union, so we can apply for resources there. But of course, government has to add a proportion of this money too. In my government, actually, leadership was secured because we understood that as a country that maybe does have a lot of resources available for healthcare, if we compare with some other countries in the world, we are not the richest in European Union, definitely not. So we have to really pay attention to use the resources carefully. And we understood that investing in preventive services does matter. So we went for it and invested in this project around more than 30 million euros. To pilot it. Now this is in the system, which means that we have to pay it ourselves. Slovenia has to secure resources. So for about 250,000 population of the biggest health center in Slovenia, which is Ljubljana Capital Health Center, we spent for these services around 1.6 million euros. This is not much per person, but if you take in account that this is invested mostly in the vulnerable group of population, this does represent substantial resources for this. And we also count on communities to invest in public health programs in their own community. For example, they can invest in NGOs working there with vulnerable groups. They can invest in premises for physical activity, or in some community programs raising awareness of people regarding the risk factors and so on. So that is a joint action between the communities and the government. Somebody was asking about the leadership. Already in a pilot, we made sure that there is a small unit at the Ministry of Health that is actually overseeing the whole operation. Then primary health care, a public health institute, as I mentioned, was in charge of coordination. They have these local entities or regional entities that were working with mayors, raising awareness of the program, of the new program, encouraging communities by the data on their health, so that they were really involved. And also, of course, the key institution was Health Promotion Center. This was the institution that on the ground made sure that all these other stakeholders were involved appropriately. They even made some action plans together for the community, so that this all has worked and everybody was encouraged to contribute.
Okay, thank you, Vesna. So we really see how the different levels, including the European level, is leveraged here. Funding from Europe to then matching government funding at the national level, and then that incentivizes local governments to invest, getting communities to invest, getting NGOs on board, mayors, etc. So it's really, getting the biggest bang for your buck, so to speak. Anyone else would like to comment on that issue of financing here?
I can for France, if you as I said, there is no real integration between public health, primary care, and social care, to be clear. There is some specific way in order to finance the way healthcare profession could deliver care and services in line with prevention, okay, or first line or second line. So, as I said, the benefit basket is very large. It's the first way to finance is with a large benefit basket. There is also some specific incentives in order to promote the access and to promote the delivery of specific care and services, including, of course, pay for performance mechanism, the interaction of family physician and GPs, for example. There is also a specific change in the payment mechanism of these primary care providers around the GPs in order to increase the rates and the proportion of prospective payments. So these prospective payments are dedicated to registered population, and the money to get is larger depending on the characteristics of the population, including, of course, chronic disease list or age or others. There is also a specific payment mechanism that complement the one at the individual level, at the practice level, and these are mainly in direction of multidisciplinary group practices, and this supplement of money helps them in order to build some specific project, and some of them are linked with the delivery of public health services. And finally, there is some specific pilot in order to increase the cooperation between different kind of providers, and maybe between GPs and nurses. And once again, here the nurses intervene in a way in order to deliver more services in line with public health, specifically for patients, in order to make some vaccination, from screening, or getting the follow-up of specific chronic conditions like diabetes or others. So these are the main levers we use at the financial level.
Okay, so expanding the benefit basket, leveraging pay-for-performance mechanisms, prospective payments, but with a catchment area or a defined population, of course, to incentivize more public health activities, supplements for multidisciplinary teamwork. I think these are all avenues for bringing in funding for more public health work. I'd like to maybe, we have very little time left, but maybe to go into the question of quality, if there's any evaluations that you do in your countries on quality of care linked to some of these mechanisms that you've mentioned and put in place in your countries. I'm looking to Kaya or Andrew, who haven't answered yet. Go ahead, Andrew.
So I'm happy to provide some thoughts to this. One is that looking at the existing evidence, it's very limited right now, and this is an area for future research that's really needed, is on when this type of integration happens, what are the effects on quality? One, though, really powerful mechanism can be investments that many countries have made in quality improvement and using it. We've seen in many countries that it can be a big lever to help support people to start thinking at a population level, and also starting to feel accountable for those population outcomes as well. But there's not a huge amount of kind of multi-country kind of research right now on that. The one other thing I want to just mention is that I think something we haven't touched on yet is also the need to create space within primary healthcare systems to do this type of work, and to just have protected time so that people within that system can think at that higher level and build these relationships. Someone in the chat mentioned, the constant urgency of the downstream and kind of always just dealing with the patients coming in again and again. That, of course, is always a barrier. So part of the key can just have some protected time to be able to engage with this.
Yes, protected time for the integration work really is really important. Vesna, I see your hand up, and then maybe we'll let Kaya speak very briefly, and then we really have to close. Go ahead, Vesna.
I will be very brief. It will be very difficult to monitor effects and say this is because of this kind of interventions and integration. Because while we are doing something in primary healthcare, and public health is supporting this at the community level, we are also trying to get our policies, public health policy right. So tobacco control, alcohol, and so on, So it's difficult to say this has happened only because of these services. But what we can see is that more people from vulnerable populations attend, and this is measurable. So we can see that they are now finally getting those services that were originally meant for them, but before, who was attending were women in early retirement who are fit and well, but they wanted to do something more for their health. They were attending services, before we upgraded those services and tried to get to the vulnerable groups with the help of course, NGOs, social services, and so on. So, it's very difficult actually to say that the impact in the society is just because of this. But you can still measure, the attendance of people from vulnerable. These kind of indicators show you that you are on the right path.
Yes, exactly. Cause and effect is always a difficult thing to measure, but of course we do have some indicators like the number of people from vulnerable communities. We will go maybe 1 or 2 minutes over time. I hope that's okay. Julien, before I get to you, I just wanted to give Kaya the chance to speak, and then we'll end with Julien, and then I will then wrap up.
Thanks. Just to reflect on the quality, and I need to say that as well as mentioned that we don't have such good integration of these two systems. So I really like what Andrew emphasized, is that you need to give a space for primary healthcare providers to give them the thinking of public health. And this is something what you can incentivize through different financing mechanisms that we use, for example, as a B4P in our case, or as an example that I mentioned, that they can just pick and choose which kind of expertise they need in addition in their team. So in Estonia has leveraged financing mechanism also from EU structural funds to build bigger teams and actually even allow to have big enough panel to include the public health nurses in the long-term perspective to the teams. But said this on financing, then also the quality monitoring of these activities comes through in Estonia through the financing schemes, because if we have defined indicators as quality indicators and we pay for them, then we do monitor the quality of these services delivered. And one of the points that did not come through the discussions, but what Andrew mentioned in his presentation, was the leadership. And I'm lucky to say that in Estonia, we do have a very strong leadership of primary healthcare providers, and this has made the whole difference in primary healthcare quality monitoring. We have a primary healthcare provider self-led accreditation system, and they were the ones to incentivize the implementation of the pay for performance system in 2006. So having these strong leaders who can advocate for integrating public health and the primary healthcare system is definitely the way to go. Thank you.
So strong leadership always comes out as important, and it comes from different sources, in this case from the primary care provider field. Julien, you wanted to just add one thing, and please go
very
ahead.
quickly, of course, I come back to the question regarding the quality. I would say two things. First, of course, we have to increase largely the amount of data we make available to the population regarding the quality of care and services delivered, including in the prevention and public health area. Second, the fact that probably we need to reinforce the pressure on the healthcare system in each country regarding the fact that when there is a pilot, when there is a new experiment, we need to have some evaluation process, and robust one, in order to make correct and robust evaluation. And we have lots of new design of pilot and experiment for which there is not real good evaluation process in order to have a look to the results. So unfortunately, we could have some of them in France regarding disciplinary team or regarding cooperation between GPs and nurses, and we have some very nice and robust estimation. But for example, for the P4P mechanism, there is no real clear evaluation of the impact on the way change practices or not, and regarding the care and services delivered for the population, and it's a pity.
Yes, so quality monitoring, obviously really important. I'm sorry we went over time. We're going to end now. I just wanted to let you know we have another PHC primary healthcare webinar next Tuesday. You see the information on your screen. And thank you all for staying a couple of minutes longer for this very interesting discussion. And we'll see you next Tuesday at 12 p.m. noon Central European Time. Thanks again, and goodbye.